The first thing I want to say was that I think, as everyone knows, autoimmune encephalitis has been an emerging entity, a really fascinating emerging entity that has incredibly debilitating consequences for the patients who suffer from these disorders. And uh, More recently, I think there has been appropriately more and more spotlight on the behavioral manifestations, the psychiatric symptoms and cognitive sequelae that arise out of autoimmune encephalitis. Um, so I am thrilled to be able to speak a little bit to everyone about this fascinating problem and talk a little bit about these manifestations. Okay, our agenda today is going to be divided into three components. First, as you can see here, I'll start by articulating a little bit about the etiology of these symptoms in autoimmune encephalitis. And next, we'll turn our attention to different kinds of uh, current interventions available for the management of these psychiatric symptoms. And then finally, on a separate note, I'll discuss a little bit about chronic manifestations because I think it is relatively divergent from some of the acute phase manifestations. Okay, so autoimmune encephalitis. I won't belabor this for very long, especially because there's many other experts on this panel who will talk much more eloquently about some of the neurologic manifestations of autoimmune encephalitis. But just in brief, as everyone knows, this is a family of disorders that results in the immune system attacking both intracellular and extracellular neuronal antigens. So this is kind of an important distinction, both histopathologically and clinically. The extracellular antigen is the one that might be a little bit more familiar to people. It's the one that we typically think of when we think of limbic encephalitis, and includes disorders such as NMDA receptor encephalitis, as well as LG1 voltage-gated potassium channel encephalitis. The mechanism at play here is thought to be involve often voltage-gated ion channels and receptor-mediated pathology that when abnormal antibodies bind to the corresponding antigen receptor, that resultant cascade of activation is thought to be what mediates pathology. The intracellular antigen mechanism we won't focus on so much in this talk, although the principles are broadly applicable. But the intracellular antigen mechanism is thought to result in abnormal T cell activation and T cell mediation of neural injury. And this group of limbic encephalitides typically includes the ones that are paraneoplastic, such as anti-Hu, anti-Ma, and anti-Yo. The part of the reason why we won't focus specifically on this mechanism, this histopathological mechanism, is because we are going to be focusing, as I mentioned, autoimmune encephalitis is a family of disorders, and we're going to be focusing on the subset that tends to cause predominantly psychiatric symptoms or refractory psychiatric symptoms. There are different kinds of patterns of clinical evolution in autoimmune encephalitis, and the intracellular mechanisms do not as commonly tend to manifest in the way that we'll be discussing. But again, these principles are broadly applicable. Okay, so what causes psychiatric symptoms? So neuropsychiatric symptoms in general, but certainly in autoimmune encephalitis, are thought to be mediated by dysregulation of certain neurotransmitters. In this case, though, the implicated ones are neurotransmitters such as NMDA, glutamate, and GABA. In particular, they're one of the widely espoused theories is the blockade of NMDA receptors or dysregulation, dysregulated active blockade of NMDA receptors in presynaptic GABA neurons, predominantly in the thalamus and the frontal cortex, leads to subsequent disinhibition of glutamate, glutamatergic neurons, and that then goes on to result in dysregulation of dopamine and glutamate throughout neurons of the frontal lobe. This also corresponds with something called the NMDA model of psychosis. And for those clinicians who are familiar with primary psychiatric disorders and their working theories, one of the more current models of the cause of psychosis is something called the NMDA model. And it's in part based on evidence that PCP causes a consistent psychosis with features overlapping with primary psychiatric illness such as schizophrenia. And in fact, you'll see that you can see that PCP can also cause some of the dysautonomia and dyskinesias, which are found also in anti-NMDA encephalitis. Research into schizophrenia, in addition, has also shown that there's evidence of NMDA receptor hypofunction, and all these different components have led to a theory that NMDA is one of the crucial dysregulated neurotransmitters in the development of psychosis. Okay, well, with that being said, what you can certainly see in autoimmune encephalitis is that really antibodies against each and every segment of different important neurotransmitters and receptors have been identified, both inhibitory and excitatory, depending on the type of limbic encephalitis. And on an ongoing basis, we continue to identify new novel antibodies and novel antigens. So again, this is part of a overarching family of problems. There's also some research and some studies that postulate that given evidence of predominant atrophy in the frontotemporal regions, which are regions with high density in NMDA receptors and glutamate and GABA receptors, that this might correlate with behavioral and psychiatric sequelae. Okay. All right, this is just a brief diagram of one of the critical receptors that we were just talking about, the NMDA receptor. And here you can see that there's two subunits, the NR1 and NR2. In general, a lot of kind of working theory is that in certain kinds of autoimmune encephalitis, particularly anti-NMDA receptor encephalitis, that abnormal antibody binding to NR1 subunits is what mediates the pathologic illness. But there's been emerging research that shows that there can be dysfunctional antibody binding to NR2 as well. And really, again, as I mentioned, every subunit of these different voltage-gated ion channels. But as you can see in this diagram, that appropriate binding of NMDA receptors by glutamate and glycine leads to depolarization activation in sort of the appropriate healthy setting. Okay. And just to reiterate, as I mentioned earlier, not all forms of autoimmune encephalitis have the same patterns of clinical evolution. Some forms manifest with predominantly neurologic phenomenon like cognitive changes, seizures, confusion, delirium. For example, LG1 is something that I might posit as something with more predominantly neurologic or common neurologic presentations. Again, here we're going to focus on forms of autoimmune encephalitis that are prominent and refractory psychiatric phenomenon as a way of teaching the overarching principles, which can be applied broadly to, in general, to psychiatric behavioral consequences in encephalitis. Okay, so a little bit about the clinical presentation. There are different models, but most models tend to divide the illness into several phases. There's some models that have 2 phases, 4 phases, 5 phases, etc. Standard models typically describe 4 phases. The first 2 phases typically present with predominantly psychiatric symptoms, and this is when oftentimes people are coming to care. And in fact, in clinical patterns of limbic encephalitis with predominantly psychiatric sequelae, such as anti-NMDA literature will cite that upwards of 3/4 of patients will initially present to psychiatric care because their symptoms are often of florid psychosis, which is clinically indistinguishable from other forms of psychosis, primary psychotic disorders like schizophrenia or drug-induced psychosis. Sometimes this is much more uncommon, but if you can retrospectively elicit from family members that there are some degree of prodromal symptoms. Very common prodromal symptoms include vague viral illness symptoms like fatigue, but you can also have different things like headaches, respiratory symptoms, or GI symptoms. And again, rarely you can, in the very early stages, you can elicit a history of cognitive symptoms, but this is relatively rare. Okay, all right. So just to talk a little bit about from the first, some of the early phases, the prodrome going, into the early acute phase. So again, this is a typical presentation for patients, and most present to psychiatric care because of the predominance of psychosis. During the early acute phase, you often see symptoms of florid psychosis like delusions, hallucinations, paranoia, again, indistinguishable from primary psychiatric illness. What is notable about psychosis in autoimmune encephalitis is that generally it's refractory to antipsychotic treatment. And oftentimes in the situation, high doses of antipsychotics end up being used to try to manage not only the psychosis, but the refractory psychosis, but also hyperactive agitation as a result of these kind of positive symptoms like delusions or hallucinations. And in particular, as patients are sort of evolving from early acute phase into late acute phase, they can often develop a lot of dysautonomia like fevers or changes in blood pressure, which can lead to, in conjunction with high doses of antipsychotics, can often lead to concern for neuroleptic malignant syndrome or anticholinergic syndrome. So that's kind of a common pitfall that can be appreciated or notable. Okay. Otherwise, in the early acute phase, be on the lookout for unusual. If you are seeing patients in primarily in a mental health capacity, some of the things that you should be on the lookout are for unusual features that don't make sense in the context of a primary psychiatric illness, such as tachycardia, dysautonomia, seizures, of course, and rapid progression to catatonia. One of the things that can make assessment very tricky, of course, is that if patients are on high doses of antipsychotics, this can often mask some of these atypical features, or it can make the picture a lot more complex. Potentially is some of the dysautonomia that we're seeing being due to a medication side effect or due to the primary process. So that's something to be aware of. And then of note, I do want to say that many cognitive symptoms are generally present in these patients, but frankly, they tend to be very difficult to assess, frankly, due to the level of psychosis and disorganization of these patients. Okay, so then as patients evolve from the early to the late acute phase, the classic clinical evolution is a rapid descent into catatonia. Oftentimes what you'll see is that the positive symptoms such as delusions and hallucinations and the agitation that results from those positive symptoms will become less prominent as patients really quickly descend into fulminant catatonia and develop waxy flexibility. Also, this catatonia is really unresponsive, is similarly unresponsive to a high dose of appropriate treatment, which in this case would be benzodiazepines. Oftentimes, in severe cases, this phase is marked by worsening dysautonomia and fevers. And again, this is the kind of period to be aware that if you are concurrently using high doses of antipsychotics to try to attempt to treat these problems, this is when oftentimes clinicians can run into a concern for NMS. And I would say that, again, and we'll talk about this a little bit later, but anecdotally, it's not clear that this kind of high dose treatment during this early phase without any kind of appropriate immunotherapy is effective. Okay, just briefly about clinical examination laboratory studies, just to touch on this, again, if you're during the because these patients are often in a sort of a psychiatric setting or a mental health treatment setting, just to be aware that you should make some assessment of the neurologic exam, which often can elicit something like hyperflexive early in the illness phase. Pay particular attention to evidence of clonus or cross-adductor responses. Laboratory features or laboratory testing in general, there sometimes can be elevated inflammatory markers, but the sensitivity of this is relatively low, and these should not be thought of as appropriate clinical evaluators. Okay, during the late acute phase, what you start to see is, again, when patients start with prodromal symptoms evolving into psychosis, next catatonia, and then during the late acute phase, there are two different kind of pathways that it's really a spectrum, but there's two general groupings that you can see patients fall under. In very severe cases without treatment, patients usually become, frankly, comatose. And what you oftentimes see in this case is dystonic posturing. You can see dyskinesias and abnormal movements. And in these cases, in terms of the psychiatric manifestations, often what you see is a lot of agitation, but it's agitation in the form of crying, shouting, or groaning. Because again, these patients are really kind of at this point bedbound and comatose, really unresponsive, but they're engaging in a lot of abnormal movements and a lot of abnormal shouting and groaning, and that often can cause a lot of agitation, which requires treatment. What in particular can be difficult about this phase is that, or this type of manifestation, is that even though patients are quite comatose and they have a lot of posturing or dystonic posturing or movements, you can still see periods of agitation, of fluctuating catatonia or agitation. This is really difficult to parse apart because patients are comatose at this point, but be vigilant for signs of things like waxy flexibility or akinetic mutism. And then, as I mentioned, there's oftentimes this can be intermixed with the shouting, thrashing, teeth grinding, and crying. Okay. Other patients tend to have a more quote-unquote gentle route, and they might not descend into the comatose state, where these patients might enter the late acute phase more in the border between florid psychosis and catatonia. This is in some ways is positive in the sense that their kind of neurologic nadir is slightly better, but in other ways there you run into different kinds of challenges, which is that in a lot of these situations you can have refractory marked psychotic activity like elopement attempts or aggression, and a lot of the psychiatric challenges in this situation, frankly, is containing patients and safely administering needed treatments. Usually by this point, during the late acute phase is historically when a lot of patients have been diagnosed either presumptively or have confirmed laboratory testing, either in CSF phagocytosis or imaging or EEG findings that are either very suggestive or pathognomonic for autoimmune encephalitis. Okay, this is a chart that, oh gosh, I'm sorry that it's a little bit, it's off the screen, but this is a chart this is made by Dr. Damo's team, and you can see this is kind of a very excellent, a really beautiful kind of representation of the phases of illness in NMDA encephalitis, which is a common kind of clinical evolution pattern in the type of encephalitis that we're talking about, the types with prominent psychiatric symptoms. And again, you can see here the initial prodrome phase followed by the acute illness phase, where they've combined uh, both positive psychiatric symptoms like delusions, hallucinations, as well as catatonia. And then neurologic complications, I'm sorry, it's a little bit off the screen, but that's the comatose phase. And then the final phase is leading into a recovery and in, in the long-term kind of prolonged deficits, which we'll touch on later. Okay, so I want to adapt that a little bit to kind of illustrate the differences in psychiatric symptoms. And here you can see something very similar. You know, again, there's a prodromal period when patients are just starting to come the change from their baseline. And during the early acute phase, you can see a lot of patients. And during that point, typically what happens first is psychosis. And in that setting, many patients have prominent delusions, hallucinations of the positive symptoms of psychosis. Agitation leads to increased activity in this phase. Um, as the illness progresses and they start to enter the late acute phase, there's development of catatonia, and then oftentimes quickly that can enter into coma. And then again, you can see here that there's two kind of overall groupings of the way that it can evolve at that point, although really it's a spectrum. But you know, for the purposes of simplification, there's two major groupings, and the worst one that we talked about is where patients stay for a prolonged period in a comatose state, even after successful cessation of inflammation. And then there's a quote unquote, maybe perhaps a milder or different course where cessation of inflammation occurs at a point when patients are still on the border between psychosis and catatonia. And during their recovery process, they spend a larger portion of their time in that kind of catatonia psychosis border zone. Whereas the sicker patients are going to be spending a significant amount of time, months at a time, in the comatose state with the corresponding kind of shouting and thrashing and that kind of agitation. Okay, all right. So next, let me move into different management options in treatment of these problems. Okay, so the main thing that I want to emphasize here, the biggest principle to keep in mind, is that time after successful cessation of inflammation is the key driving factor in resolution of psychiatric symptoms. Really, nothing else really has the same level of importance in resolution of behavioral manifestations. Everyone knows, a treatment of autoimmune encephalitis typically involves a course of immunosuppression, starting with a standard course of pulse-high-dose steroids, followed by next either IVIG or plasmapheresis. Unresponsive cases then will, or not only unresponsive cases, but also in certain appropriate clinical scenarios, patients will then proceed to maintenance chemotherapy, immunomodulation, Cytoxan was an older medication. There's other new forms, including Rituxan. And then, of course, during this phase, there is a search for solid organ tumors or neoplasm of various kinds. Okay, so the management approach of psychiatric symptoms is usually, psychiatric care is usually involved in for two different reasons. First, it requires management of agitation, the different forms of agitation, and secondly, there is needed management of catatonia. And because the two tend to be quite different, they tend to clinically manifesting quite differently. They require different kind of, very different approaches that will separate. Okay. So just in brief, catatonia management, as in any other form of catatonia, typically involves high doses of benzodiazepines or benzodiazepines in general. ECT is a rarely used treatment that has demonstrated efficacy in case reports, but we really have, I will say frankly that I think it's an underutilized treatment, and we really need to, there needs to be more research in this area. Agitation, of course, is typically treated by a number of different options, including primarily antipsychotics. Atypical antipsychotics are most commonly chosen. Most of the literature, existing literature, although it is sparse, discusses medications like low to mid potency agents such as quetiapine, olanzapine. High dose agents have been used, such as risperidone and haloperidol. Some of the literature suggests concurrently using certain kind of medications to prevent EPS, anticholinergic medications to prevent EPS concurrently with high-dose antipsychotics. Again, there's really limited literature about this. As I mentioned earlier, during the acute illness phase, before cessation of inflammation, I would suggest being judicious about antipsychotic use, because again, these kind of symptoms tend to be very refractory, and during this time period before cessation of inflammation, this is the period that tends to have a lot of dysautonomia and fevers, and you tend to run into clinical concern for things like anticholinergic syndrome and NMS, which obviously can be a very devastating complication that you don't want to run the risk of. And then finally, Depakote and other mood stabilizers, but really primarily Depakote, are also commonly used for agitation. It has a bonus of additional seizure control, and then in the chronic setting, it can be used to some degree for brain injury and sort of the impulsiveness or aggression and cognitive issues that come from long-term brain injury. Okay, so just a couple guiding principles about this. One of the main things that I would emphasize is that changes as a result of medication dose alterations or introduction of new medication typically take a couple days to establish a clear pattern of effective or not effective or any changes. So I would emphasize that slow and steady medication changes are paramount here, and to resist as much as possible the urge to act reactively. Especially in these situations, with these very sick patients, there is always a lot of kind of temptation to want to try to make aggressive or quick changes. I would encourage everyone to resist that urge and to make slow and steady changes. As you have seen from other talks, and also as I mentioned earlier, the timeline of these disorders is very long. Even from the onset of the illness into kind of the late acute phase is typically at least about a month, and then the period of time that severe cases are spending in that kind of initial recovery period, where they're still often kind of very comatose and they have a lot of shouting and thrashing even after cessation of inflammation, that kind of period for severe cases can take several months. So again, remember to be patient. Recovery typically starts really at the 6-month mark to 1 year, and stable long-term recovery is usually over several years. It usually takes several years to reach. And then one of the things that I encourage everyone to do is use those charts about expected clinical evolution to guide your treatment. As you can see, at each stage of the illness, there is a very different presentation, very different phenotypic manifestations of agitation, catatonia versus psychosis, or just a frank comatose state. As you can imagine, each of these very different states can often require a different treatment approach, and it can be very confusing to parse apart exactly what's going on, the difference between, say, catatonia and a comatose state, or delirium. And for that reason, my recommendation is that clinicians should remain flexible but be patient in your approach. Okay, just a little bit about antipsychotics. High-dose antipsychotics are often necessary for significant agitation. So in regards to complications, one of the biggest complications that you can review in literature is the risk of NMS and EPS, as well as anticholinergic syndrome. Some of the literature, some of the reviews, limited review studies cite almost up to 10 to 20% of the time high-dose antipsychotics can be stopped out of concern for causing the above complications. One of the caveats that I would add to that is that it's not clear from the literature when in that time course it happened. Again, one of the suspicions that I would have is that a lot of this tends to happen before successful cessation of inflammation, and there's a lot of fevers, a lot of dysautonomia. That's likely to be a time point when there's a lot of clinical concern for NMS. Also, the second thing I would say that the true incidence of something serious like NMS is actually unknown, because in a lot of these situations, the antipsychotics end up being stopped out of concern. So the incidence of true NMS is really unknown. Okay, as I mentioned earlier, the literature suggests low to mid potency agents as atypical agent antipsychotics as first-line agents, but really I think one of the things that I would emphasize is the range of atypical agents, and then also how they'll have been very safely used and are described. You can see here I've kind of described anecdotal experiences as well as what's in the literature. And in quetiapine, you can see ranges up to 1 gram daily, which is a frequently chosen agent because it's very sedating and it's low potency. Zyprexa or olanzapine has been used from 10 to 20 milligrams and is a mid to high potency agent, also very sedating. And then Haldol is used in ranges of something like 5 to 10, and risperidone 1 to 6 milligrams and are anecdotally described. Okay. Because psychosis symptoms are typically refractory to antipsychotic management, again, I would recommend cautious and judicious use of antipsychotics prior to cessation of inflammation. After a successful resolution, again, the literature is pretty clear that these have been effective and safely used. The goal of antipsychotic administration is to reduce morbidity in the form of agitation while awaiting time recovery of manifestations of inflammation. Okay, and then most common side effects are Parkinsonism, like drooling, stiffness. You can also see sedation and bradykinesia. Okay. Benzodiazepines. So benzodiazepines are widely described in the limbic encephalitis literature of what's out there in terms of behavioral management, although to some degree details on dosing and complications is actually quite limited. What literature that does exist certainly suggests that daily dosing ranges in refractory catatonia can range up to 50 to 30 milligrams. Although oftentimes the dosing can be less than that. Both lorazepam and clonazepam are chosen agents due to kind of their onset time and duration of action. Okay, one of the things that I would also suggest that if patients are sedated or comatose around the 3 to 6 month mark, that's when patients their mental status starts to improve. And if you're on very high doses of benzodiazepines, it can potentially preclude an accurate assessment of their level of arousal, so just be aware of that. And then also another point that I would suggest is that they're often used for agitation. This can be very effective, but sometimes you can see if it's used in a PRN context and there's a lot of fluctuation in the dose of the benzodiazepine, there can be a corresponding amount of fluctuation in the mental status. For example, benzodiazepines can be very effective for agitation, but they might lead someone to become drowsy or more frankly a depressed mental status. And then with resolution of the benzo, or when the benzodiazepine wears off, then that can quickly maybe return to refractory agitation or sort of rebound agitation. So that can create a kind of seesaw effect, which can make it extremely challenging to manage these patients. So be aware that in general, it might be preferential to use standing benzodiazepines rather than PRN benzodiazepines. Okay, mood stabilizers. There's a very limited literature about this. Case reports do cite relatively commonly the use of Depakote, and in autoimmune encephalitis literature. Typically, in the literature that is out there, Depakote is not used in isolation, so its efficacy compared to antipsychotics and benzodiazepines is hard to know. It's often also selected as an anti-epileptic, and it has that bonus. Doses are typically titrated, aiming for a serum trough level of around 75. Okay, ECT. Again, ECT is something that is cited in literature as being anecdotally very effective, especially in refractory catatonia. The accounts all generally occur concomitantly or after, administration of immunosuppression. So that would be my recommendation. I will certainly say that, again, this is an underutilized treatment in severe cases, and might potentially be really, I would suggest that more research in treatment of severe cases is merited. Just briefly touching on other agents, clonidine has been used in agitation. Again, it's used in tandem, often with a lot of different other agents, so it's difficult to know the potency of clonidine. Different anticholinergic agents such as Pojen Deng or trihexyphenidyl can be used to treat EPS or reduce the risk. And of course, be aware that during the early stages, when there is concern for things like anticholinergic syndrome, these agents might be less desirable. And then finally, in severe agitation cases, there is literature that describes the use, and anecdotally, I would say also Precedex propofol and continuous sedation benzodiazepines have also been used. I think the main principle here is that might occur during a period of time when assessment of the level of arousal is less critical, for obvious reasons. Okay. Finally, I want to touch upon chronic behavioral manifestations. And this is one of the least understood aspects of autoimmune encephalitis. Existing literature, which is sparse, cites that really as many as 3/4 or upwards of 3/4 of patients return close to their baseline level of functioning. What we've come to know over time, though, what we've come to identify more and more over time is that even these patients have subtle cognitive and executive function deficits, which might which in comparison might seem relatively mild, but certainly for a lot of these patients that were very high functioning before, it can be meaningful changes. Other patients can have long-term sequelae in the form of abulia, flattening of the affect, akineticism, anhedonia, and then mood disorders, anxiety, and fatigue are also very common. It's really unclear what risk factors might differentiate long-term recovery, although certainly age, the intracellular versus extracellular mechanism, and then also time to initiation of treatment have been identified as 3 important risk factors. Okay. Again, this is a big area of research. There are limited case reports that don't show any association between imaging or testing findings and evidence of long-term sequelae. One of the things that I do want to mention in literature is that, again, the sample size is very small, but there are, again, subtle deficits in memory and executive function. And the theory is that, again, important neurotransmitters in the causes in the etiology of psychosis, such as NMDA, are also involved in learning and memory, and their predominance in structures such as the hippocampus, which can be affected in the long term. Okay, long-term management, I think I'll focus on the psychotropics. Stimulants, different types of stimulants, Adderall, Ritalin, and modafinil, have some use in modestly improving motivation, energy, and engagement. Just pay attention to the level of agitation as well as any kind of worsening of mood or anxiety issues. Mantidine and Depakote have also been employed successfully, again, although with modest success. And finally, SSRIs are one of the mainstays of treatment of symptoms such as abulia or pseudobulbar affect, things that you can see in long-term sequelae of autoimmune encephalitis. The anecdotal accounts are pretty limited, and the overall efficacy is unclear. One of the last things I do want to touch upon is that there's not a lot of um, uh, this is really kind of, an incredibly devastating disorder that it takes away such a huge segment of time for patients, and also in addition for patients' families or who are kind of present during that experience. This is a really rare disease with limited resources and avenue support, and I think that these are kind of under discussed areas that I want to raise awareness of, so that we can better identify resources to help both patients and families coping with such a debilitating illness.